Welcome to Deep Dive Ortho. Today we're getting into a condition that, well, it can be a real puzzle in the clinic. Posterior Interosseous Nerve Syndrome, PTs.
Hmm.
It's one of those rare nerve compression issues in the forearm, but the way it presents often means it slips under the radar, doesn't it?
It certainly can.
Yeah.
Very subtle sometimes.
So we're going to explore what makes it unique, how it actually shows up in patients, and look at the best ways to diagnose and treat it now. And joining me is Professor Mo Imam, an expert in navigating these sorts of tricky neuromuscular problems in orthopedics. Professor, what are we hoping our listeners take away today?
Well, the main goal is to give you, our colleagues in the field, a really solid grasp of PENS. We want to clarify the pathology, yes, but also really highlight those diagnostic clues that help you tell it apart from other things.
Things it often gets mistaken for.
Exactly. And then cover the effective management strategies, from conservative approaches right through to surgery. It's about providing a clear, practical roadmap, really.
Excellent. So let's dive in. What exactly is posterior interosseous nerve syndrome? What makes it stand out from other nerve compressions?
Okay, so PNs is essentially an entrapment neuropathy. Specifically, it affects the deep branch of the radial nerve.
The deep branch, right?
And what's really distinctive, the key thing, is that it overwhelmingly affects motor function. So patients get muscle weakness. But, and this is crucial, they typically don't have sensory symptoms. No numbness, no tingling.
Ah, so purely motor. That is different.
It is, and that's a major clue compared to many other neuropathies. It is quite rare, mind you. We're talking maybe 3 cases per 100,000 people per year. So less than 0.7% of all upper limb nerve syndromes.
That is a low number, which probably explains why it can be missed.
Precisely. It's not front of mind for many clinicians.
So where does this nerve actually travel? And what typically causes the compression?
Right, so the posterior interosseous nerve, the PN, branches off the radial nerve around the elbow at the radiohumeral joint line. It then dives deep, traveling through what's called the radial tunnel, a really critical spot. And the most common place for trouble is the arcade of Fros. This is a sort of thickened fibrous arch at the edge of the supinator muscle.
Adafros, got it.
That's the main culprit, usually. But there are other potential pinch points. Fibrous bands near the radial head, something called the leash of Henry, which are recurrent blood vessels.
Right.
The edge of the extensor carpi radialis brevis muscle, and even the distal edge of the supinator.
So quite a few potential anatomical traps.
Indeed. And the cause can be varied too. Anatomical variations, space-occupying things like lipomas or ganglion cysts, direct trauma, inflammation perhaps from rheumatoid arthritis, even sometimes after surgery, iatrogenic causes. And repetitive movements, lots of forearm rotation, pronation, supination, that's a big risk factor too. It can thicken that arcade of Fros. We see that in, well, studies suggest 64% to 87% of PINS cases.
That's a high percentage linked to that specific structure.
Okay, so knowing the anatomy is one thing, but clinically, what symptoms should really raise a flag, and how do we reliably tell PINS apart from its mimics? Well, the onset is typically quite insidious, slow, which is partly why it can go undiagnosed for, sometimes 2 or 3 years on average.
Wow, that long.
It can be, yes. The absolute defining symptom is motor weakness, specifically weakness in extending the fingers and the thumb at the MCP joints. This really impacts grip and daily tasks.
Okay.
Now, interestingly, wrist extension is usually okay because the extensor carpi radialis longus, the ECRL, is innervated before the PN branches off.
Ah, I see.
But you might see the wrist deviating radially toward the thumb side when they try to extend it. That's because the extensor carpi ulnaris, the ECU, and the extensor carpi radialis brevis are weak.
So it's not a full wrist drop like in a higher radial nerve palsy?
Exactly. It's often called finger drop rather than wrist drop or dropping hand. You might sometimes get a positive tenal sign over the nerve pathway indicating irritation, but that's variable.
And again, crucially, no sensory loss.
No sensory loss. That's the cardinal feature to remember.
Which, as you said, is key for differentiation. So what are the main conditions it gets confused with?
Yes, very important. Radial tunnel syndrome is a big one. It involves compression in the same general area, the radial tunnel.
Right.
But the key difference is that radial tunnel syndrome presents primarily with pain. Dorsiradial forearm pain, often aching, radiating down, maybe tender, about 3 to 5 centimeters distal to the lateral epicondyle. It's often mistaken for tennis elbow. But crucially, there's no motor weakness.
Pain, but no weakness. Okay.
Then there's Wartenberg syndrome. This is compression of the superficial sensory branch of the radial nerve,
Yeah.
usually down to the wrist, between the brachioradialis and ECRL tendons.
So purely sensory.
Purely sensory. Patients get numbness or pins and needles over the back of the thumb and index finger area, the dorsal radial hand. Absolutely no motor weakness.
Okay, so clear distinctions if you look carefully. Pins is motor only, radial tunnel is pain only, Wartenberg is sensory only.
Precisely. That framework is very helpful.
So, given these nuances, what's the best diagnostic pathway? How do things like EMG, ultrasound, and MRI fit into confirming pins?
It really needs a combination approach. Clinical suspicion is first, of course, based on that pattern we discussed. Then electrodiagnostics, EMG, and nerve conduction studies are really key.
What do they show specifically?
They can pinpoint the level of compression. You'll see reduced or blocked motor nerve conduction across the likely site, say the forearm segment, and reduced signal amplitude in the muscles the PN supplies, like the extensor digitorum.
Okay.
And importantly, they will confirm that the sensory nerve conduction studies are normal. This reinforces that motor-only picture. But EMG can't tell you why the nerve is compressed.
It shows the what, but not the why.
Exactly. That's where imaging comes in. Ultrasound is often the first port of call now. It's actually very good for this.
Better than you might think.
Yes, it's excellent for looking directly at the nerve, measuring its size. Often it's swollen just before the compression point. For instance, one report showed the pinnacle and swelling to 1.5 millimeters versus 0.6 millimeters on the other side, just before the arcata froze. Other studies show average diameters like 1.79 millimeters in affected nerves versus maybe 1.02 millimeters in controls.
That's quite a difference.
It is. And ultrasound can also assess the surrounding structures, look for cysts or thickened bands, and it's dynamic. You can see how things look during movement sometimes.
An MRI, where does that fit?
MRI is invaluable, particularly for looking at the muscles. You might see signs of denervation, like swelling or increased signal on certain sequences, or even muscle atrophy if it's been going on a while.
Like in the supinator muscle.
Yes, especially the deep part of the supinator. MRI is also better for spotting things like tumors or perhaps deep inflammation, things ultrasound might miss. One review found muscle changes in over half of PINS patients and extrinsic masses in about 28%.
So they complement each other well?
They do. Radiographs, plain x-rays aren't routine unless you suspect a bony cause, maybe an old fracture fragment or something. It's a clinical picture plus EMG plus targeted imaging that gives you the answer.
Right, putting all the pieces together. So once you have that confirmation, what are the treatment options? What's the general approach?
Well, initial management is usually non-operative, conservative.
Okay.
So rest from aggravating activities, maybe modifying how they do things, splinting the wrist and slight extension perhaps, anti-inflammatories.
Standard stuff first.
Pretty standard first-line approach, yes. Sometimes injections are considered, maybe a corticosteroid injection near the nerve, carefully done. Or some centers use perineural injections with 5% dextrose to try and hydrodissect the nerve a bit.
Interesting. And physio?
Oh, absolutely critical.
Yeah.
Physiotherapy focusing on strengthening exercises for the weakened muscles, but also nerve gliding exercises to try and improve the nerve's mobility through that tunnel.
And if conservative measures don't work?
Then surgery comes into play. Surgical decompression is usually considered if there's no improvement after, say, at least 3 months of good conservative management, or if imaging clearly shows a compressive lesion, like a cyst or tumor, that needs removing anyway.
And what does the surgery involve?
The aim is to release all the potential compression points along that pathway we discussed. So releasing any tight fibrous bands, dividing the leech of Henry if it's constricting, releasing the edge of the ECRB muscle, and definitely, crucially, releasing that arcata frost and any tight spots in the supinator muscle itself.
A thorough decompression.
Yes, you need to ensure the nerve is free along its course in that region.
And what's the prognosis generally like? What can patients expect after treatment, whether conservative or surgical?
The outlook is actually generally quite good for PINS. Many patients do experience significant improvement. What's quite striking is that spontaneous recovery without surgery has been reported in a high percentage of non-traumatic cases, maybe 75% up to even 97%.
Really? That high?
Yes, the nerve seems to have a decent capacity to recover if the compression isn't too severe or prolonged. After surgery, patients usually start gentle active movement fairly early, and recovery can continue for quite some time. Full motor recovery might take many months, potentially up to 18 months, especially if the nerve was compressed for a long time before intervention.
So patience is needed.
Definitely. It's important to manage expectations. POK decompression might not always give the sort of immediate dramatic results you sometimes see with, say, carpal tunnel release.
Right.
And the real issue is delay. If diagnosis and treatment are delayed significantly, you can get irreversible muscle changes, fibrosis. In those cases, sometimes tendon transfers are needed later on to restore function.
Which really brings us back to the importance of catching it early.
Absolutely. Early, accurate diagnosis is key to the best outcomes.
Well, this has been incredibly illuminating. Thank you for walking us through the complexities of posterior interosseous nerve syndrome. It's definitely clear that while it might be rare, really understanding PINS is vital for spotting it and managing it effectively.
My pleasure. I think the main message for everyone listening is the value of that careful clinical assessment, really listening to the patient and examining them properly, combined with using EMG and imaging smartly. Recognizing that specific pattern motor weakness, no sensory loss, and knowing where to look for compression, that can make all the difference in getting patients diagnosed much sooner.
Absolutely. It's a fantastic example of how connecting those seemingly subtle dots in the clinical picture can lead to really significant, potentially function-saving interventions. If you found this deep dive valuable, please do consider rating and sharing the show. It really helps us keep these conversations going. And as you think about this discussion, perhaps consider, how might this detailed look at PNs change how you approach a patient who comes in with that vague, unexplained forearm weakness? What questions might you ask now, or which diagnostic steps might jump higher up your list to make sure this elusive condition doesn't get missed?